All right, let's get right into this explainer. Today, we're breaking down some seriously high-yield, heavily tested medical board concepts using rapid-fire clinical vignettes. If you're prepping for exams, or honestly, just looking to sharpen your clinical reasoning, you are in exactly the right place. We're going to treat this just like an active ward round. I'll give you the question, the options, and then, most importantly, the critical exam pearls that reveal the underlying medical science.
Here's our syllabus for today's rounds. We'll cover the mechanics of wound dressings, dive into MRI fundamentals and safety, look at the clinical utility of MRIs, tackle imaging for bony metastases, and wrap up with bone scans in oncology. Let's lock in those points.
Moving on to Section 2, MRI fundamentals and safety. Let's see how you handle our MRI safety gauntlet.
Read carefully on this one. We are specifically looking for the statement that is fundamentally incorrect. You know how it is in medical exams. One single word can completely flip the entire meaning of a sentence, so read every single option like a detective.
Let's check out the options. A. Not associated with ionizing radiation. B. Depicts excellent soft tissue contrast. C. Absolutely contraindicated in pregnancy. D. Is an expensive investigation. E. Associated with long scan times. Look really closely at the phrasing here, especially when extreme words like absolutely get thrown into the mix. Is it an expensive investigation? Yup. Does it have long scan times? Absolutely. Excellent soft tissue contrast? That's exactly what it's famous for. So, we're really down to A and C.
And the false statement is C. Because MRI doesn't use ionizing radiation, it's actually only a relative contraindication during the first trimester. This restriction is mostly due to theoretical concerns about how high-intensity magnetic fields might impact early organogenesis. So sure, we reserve it for situations where alternative imaging just won't cut it, but it is definitely not an absolute ban.
This table brilliantly illustrates the exact exam pearls you need to memorize to navigate the danger versus safe zones of the MRI suite. Absolute contraindications, things like pacemakers, intracranial ferromagnetic aneurysm clips, and ocular metallic fragments. Why? Because the magnetic field could literally rip these out of place or fry the electronics. Meanwhile, severe claustrophobia and first trimester pregnancy are just relative. And surprisingly, modern non-ferromagnetic stuff, like laparoscopic titanium LIGA clips or silicone breast implants, are totally safe.
All right, Section 3, Clinical Utility of MRI. Let's pinpoint exactly when this type of imaging is your best possible tool.
MRI is superior in the assessment of which of the following. As you read the choices, think about what kinds of tissues an MRI visualizes best, especially compared to a standard CT scan or a plain old X-ray.
Here we go. A. Pregnancy in first trimester. B. Occult hepatic metastasis. C. Spine and soft tissue lesions. D. Malignant metastasis with implanted pacemakers. E. Ocular metallic foreign bodies. Let's use some rapid-fire elimination based on what we literally just reviewed. We know pacemakers and ocular metallic foreign bodies are absolute contraindications, so D and E are out immediately. We also know it's a relative contraindication in the first trimester, which knocks out A.
Leaving us with C, spine and soft tissue lesions. The crucial takeaway here is that MRI provides unmatched, multiplanar visualization of the spinal cord, spinal fluid spaces, intrinsic ligaments, and soft tissue masses. When you're trying to evaluate disc herniations, cord compression, or spinal tumors, an MRI easily outperforms a CT scan.
Which brings us to Section 4, Imaging for Bony Metastasis. Let's tackle a classic, super high-yield board prep trap. We've got a 49-year-old male with renal cell carcinoma experiencing relentless lower back pain. A bone scan comes back inconclusive, but your clinical suspicion is high. What is the next best investigation? The stakes are high here. Your patient is in agony. You strongly suspect metastasis, but your standard screening test, the bone scan, just betrayed you. What's your next move?
Let's look at our options. CT scan, MRI, rebone scan, plain X-rays, or a PET scan. Think about this systematically. A plain X-ray simply won't show early structural changes. And repeating the exact same inconclusive bone scan, that's just a waste of time. We need to select the absolute most sensitive modality for early marrow infiltration.
And that makes the correct answer B, MRI. When a bone scan gives you a false negative, but your clinical suspicion of metastasis is still screaming at you, an MRI is the absolute best next step. See, MRI directly images the bone marrow space rather than relying on cortical bone turnover. That lets it detect early tumor infiltration and spinal cord compression way before any significant bone destruction actually happens.
But why did that bone scan fail in the first place? Guys, this is the ultimate exam pearl. Radionuclide bone scans rely on osteoblastic, or bone-building activity, to show up as hotspots. This perfectly explains why purely bone-destroying osteolytic lesions, like the ones you see in renal cell carcinoma, thyroid carcinoma, and multiple myeloma, give us dangerous false negatives on standard bone scans. They are destroying bone, not building it, so the scan just doesn't light up.
Let's quickly review this diagnostic pathway. It's airtight, and you must follow it. Step 1. Strong clinical suspicion of metastasis. Step 2. Standard bone scan, which returns inconclusive. Step 3. Don't stop there. Order that MRI to detect marrow infiltration. If the clinical picture screams metastasis, but the bone scan is completely quiet, you step it up to an MRI immediately.
Final section, number 5. Bone scans in oncology. For our last concept of the day, let's clarify when a standard bone scan actually does shine.
Bone scan is best for which of the following pathological conditions? A. Stress fractures. B. Avascular necrosis. C. Bony metastasis. D. Malignancy. E. Soft tissue lesions. Based on everything we just discussed about osteoblastic versus osteolytic activity, see if you can spot the classic indication for a technetium-99m phosphonate bone scan.
The correct answer is C, bony metastasis, but specifically osteoblastic ones. While bone scans are fantastic, cost-effective screening tools for osteoblastic prostate or breast cancers, they aren't the end-all be-all. Notice the second row here. While bone scans can technically show stress fractures, an MRI is actually preferred in real clinical practice to pick up early marrow edema. So I'll leave you with this thought to carry into your next shift. While algorithms and high-tech imaging modalities are incredibly powerful tools, isn't it amazing that trusting your own clinical intuition over a single equivocal scan is what ultimately saves a patient's life? So what happens when you start trusting your exam more than the screen? Think about it. Thanks for joining this explainer, and I'll catch you next time.